Susanna Leisure is the chair of the International Stillbirth Alliance, co-chair of the Stillbirth Advocacy Working Group that was founded by the WHO's Partnership for Maternal, Newborn, and Child Health, a member of the Every Newborn Action Plan Management Team, and a fellow at the Stillbirth Center for Research Excellence at the University of Queensland in Australia. She is also a doctoral student in epidemiology at Columbia University. Her dissertation focuses on structural racism as a cause of racial inequity in stillbirth rates and methylation of stress-related genes as a mechanism by which maternal stress may increase the risk of stillbirth. Before moving to epidemiology, Ms. Leisure spent 25 years working on global poverty alleviation in Asia, Africa, and Central America, including 10 years working and living in Vietnam. She holds master's degrees in economics and epidemiology from Johns Hopkins University and the London School of Hygiene and Tropical Medicine. Ms. Leisure is the mother of 3 living sons and Wilder Daniel, her first child, who was stillborn in 1999 after a perfect pregnancy with no cause ever found. Her presentation is titled Getting Stillbirth on the Global Agenda and Implications Lessons Learned for the Stillbirth Community in the USA.
Hi, I am going to share my screen and begin my slideshow. So thank you so much on behalf of the International Stillbirth Alliance for the invitation to speak today. I will be talking about getting stillbirth on the global agenda and implications for the US. So here is why I care about stillbirth. This was me in 1999, very pregnant and excited for my first child. And here is me on July 13th, 1999, after the stillbirth of my son, Wilder Daniel, at full term after a perfect pregnancy with no cause found. So I do this work for my son, Wilder. So I love this word cloud. This is from our conference badges from the ISA conference in Cork in Ireland in 2017. And it sums up how we felt and still feel about stillbirth, how passionately we feel. Here is how the rest of the world sees stillbirth. This is the famous word cloud from the Lancet's 2016 series on ending preventable stillbirths. And it includes the 500 most commonly used words in a collection of key global health documents. And you can see sort of how the maternal and child health community still makes stillbirth invisible. So what's one thing that you could do? Come up with a powerful graphic like this one that sums up the invisibility of stillbirth in the US. This graph is called the Bending the Curve chart. In 2014, the World Health Assembly adopted a resolution to end preventable newborn deaths and stillbirths. So that was the very first global stillbirth rate target. And the aim was to reduce all countries' stillbirth rates to no more than 12 per thousand. The chart is also from the Lancet's 2016 series, and so it's a bit out of date. You can see that the line is pointing downward. That's a good thing. But the decrease was not fast enough in 2016. To reach the global stillbirth rate target by 2030, the rate of reduction would have had to more than double. So how are things looking today? In some ways, they're a lot better. There's been a 35% cut in the stillbirth rate since the year 2000. But progress is slowing down, and it's still worse than progress on under 5 mortality. In 2020, 56 countries are not on track to meet the global target by 2030, and 34 of them won't even meet it by 2050. Only 14 countries cut their stillbirth rates in half, and 80 countries had reductions of less than 25%, much less than the global average. That includes the US. So what's one thing that you could do? Find out how the stillbirth rate in your state compares to mortality rates for other groups. The infant mortality rate is a good place to start. Why are there differences, and how can your state do better? So other than our shared humanity, Why do we care about the global target rate? After all, the US national rate is already below the target. Here is one reason. The stillbirth rate for African Americans today is the same as for white Americans 40 years ago. That is obviously unacceptable. At a national level, we're doing poorly as well. The US stillbirth rate of 3 per thousand, that's using the global definition of 28 weeks or more, puts us behind 33 other countries. Globally, there's huge disparity on progress on stillbirth reduction. You can see here that the best performers in terms of reducing their stillbirth rates are actually some of the lower income countries. Turkey and China had the fastest reductions at 5.3% per year. In contrast, the US average rate of reduction was just 0.5%. We were therefore at number 182 out of 195 countries that were assessed. So what's one thing you could do? Find out what action you could take in your own state to push to match the progress of Turkey and China. We can see that progress is possible just by looking at these statistics. Globally, millions of babies' lives could be saved between now and 2030 if each country reached the high-income country average of 3 per thousand, which is where the US is now. But what if your own state or community reached that goal also? That's called a subnational target, and it's part of what we advocate for globally. So what's one thing you could do? Calculate how many babies could be saved if your state or community could reach the lowest known stillbirth rate by 2030. That's Japan, 1.4 per thousand. Get on social media to make the case that even though the US has one of the worst track records of any country on reducing the stillbirth rate, you believe we can and must do better. So as many of you know, the Lancet's Ending Preventable Stillbirth series put out a call to action for stillbirth prevention and support in 2016. The call to action includes the global stillbirth rate target of 12 per thousand, but it calls for more than just that. We call for all countries to set targets to reduce inequity in stillbirth rates within their borders. That's the subnational target, and then meet those targets. We call to extend family planning services and ensure high quality reproductive and pregnancy care for all women, to achieve a global consensus on bereavement care after stillbirth and help end stigma. ISA created a global scorecard to track progress against the call to action. I know you can't read all the text in that small graphic, but you can see all the red, so you know it's not good. What's one thing you could do? Compare the call to action to progress in your own state or city and decide what's most important for stillbirth prevention and support in your own community. So the call to action was needed because preventable stillbirths and poor quality bereavement care are still happening. There's progress, but as we just saw, the progress is too slow. To speed up, we need to understand what's holding us back. So I really like this framework. It's by Jeremy Schiffman. It outlines the factors that tend to help or hinder global attention to public health issues. The framework has been used to better understand maternal deaths and newborn deaths. And I think it's also really useful for understanding what's going on in stillbirths. So we all know that one factor that's holding us back on progress is lack of high-level political interest in stillborn babies. Sad, but true. Why is this? The harsh reality is that progress on stillbirth is slow, in part because all over the world, it's the marginalized and disempowered who are more likely to be stillborn. By far, the largest number of stillbirths occurs in low and middle income countries. 340,000 babies are stillborn every year in India alone, and another 650,000 in Pakistan, Nigeria, Congo, China, and Ethiopia. But as many of us know from personal experience, stillbirth is not only a low and middle income country issue. In every country, whether high or low income, stillbirths occur more often among the marginalized. In Ireland, babies in the poorest regions there are over 3 times as likely to be stillborn as babies from wealthier regions. In Australia, Indigenous families are 1.5 times more likely to suffer a stillbirth. And in the US, as I already mentioned, non-Hispanic Black Americans have a rate of stillbirth that is more than twice as high as white Americans. So what's one thing you could do? Find out what the biggest disparities in stillbirth rates are in your own state. They may be along racial lines or nationality, poverty, or other things. Then figure out how to use that data to demand change. Progress on stillbirth is also hampered because of the taboo on talking about it. Talking about live babies is okay. Talking about dead babies, not so much. Too often, stillborn babies are dehumanized, stigmatized, viewed fatalistically as unpreventable, ignored, and marginalized. Stillbirth babies become invisible. It's really hard to make progress on a global public health issue when you can't even talk about the subject. So what's one thing you could do? Strategize about how to make headway in reducing stigma about stillbirth in your own community, and then take action. Global norms determine how people interact, behave, decide things, even how they think, and they set the tone for what matters both globally and locally, politically and personally. For stillbirth prevention, global norms have been a powerful force. In the year 2000, the Millennium Development Goals left out stillbirth. In the year 2015, the Sustainable Development Goals also left out stillbirth. This is the cover of the Global Strategy for Women's, Children's, and Adolescents' Health. It implements the Sustainable Development Goal number 3, which is the health-related one. And as a sort of crude measure of the insufficient attention to stillbirth, the global strategy mentions the word child over 300 times, the word stillbirth, a grand total of 6 times. However, there has been progress. The global stillbirth community had a big win during negotiations about indicators to measure implementation of the global strategy, and the stillbirth rate does appear as an indicator of progress right along with the maternal under 5, newborn, and adolescent death rates, even though it's not in the SDGs. More recently, the Every Newborn Action Plan, which is the platform that set out the global stillbirth rate target, set forth new targets for 2025 that strongly reflect action on stillbirth. And just last October, UNICEF and WHO launched the first regular country-specific stillbirth rate estimates, which is fundamental for tracking progress. But it took a long time. All global public health issues exist within a cultural and historical context. A key component of that rich context is the history of human rights work, which started in 1948 with the Universal Declaration of Human Rights and continued in the 50s and 60s with other key declarations on the rights of the child and the elimination of all forms of racial discrimination. These may seem not to be directly related to stillbirth prevention, but they really are. It's through global agreements like these that global norms on what is and is not acceptable slowly begin to shift. In 1978, the landmark conference on child health that was held in Alma-Ata in Kazakhstan focused global public health attention for the first time on the grave importance of reducing child deaths and improving child health care. That conference marked a shift in global attention. The same thing happened in 1987 at the first World Conference on Safe Motherhood that was held in Nairobi in Kenya. It had a huge impact on global public health attention to the burden of maternal deaths. In the last 20 years, global norms on maternal and child deaths as both unacceptable and preventable, and on human rights as universal, have been sustained and strengthened. And a new focus on newborn survival and prevention of newborn deaths and prematurity has begun to grow. The capstone of this shift in global norms was the 2014 World Health Assembly resolution in support of the Every Newborn Action Plan, which, as you now know, set the global target rate. That occurred just 7 years ago. Stillbirths have indeed lagged behind. The first global stillbirth rate estimate was only done in 2006, and the first country-specific estimates in 2011. And it was just 1 year ago, less than a year, that the world finally agreed to collect this data regularly. So what's one thing you could do? I think it would be great to create a timeline of US historical progress on stillbirth. I think it could be put to very good use. Another key factor that holds back progress on stillbirths relates to its preventability, which is pretty ironic. Detection and treatment of syphilis, hypertension, diabetes, and fetal growth restriction, folic acid supplementation, and induction at 41 weeks, together with emergency obstetric care, are some of the widely known and medically accepted practices that can prevent most stillbirths. Stillbirths can also be prevented by a wide variety of other interventions, from reducing exposure to smoking and environmental toxins to preventing child marriage and domestic violence. Policy interventions, including access to birth control, can also help. In 2011, this estimate found that well over 1 million stillbirths a year could be prevented with these known interventions. That's still true today. Here's a graph from the UNICEF report from last October showing that still over 40% of all stillbirths occurred during labor and delivery. Those are intrapartum stillbirths. Virtually all of these could have been prevented. Even in high-income countries, about 6% of stillbirths are still intrapartum. That's about 700 a year in the US, or 2 per day. We know the low rates of stillbirth are possible because we see them in other high-income countries. But high rates among disadvantaged groups and areas in the US, that's part of what drives our unacceptably high national stillbirth rate. This summary from The Lancet shows key factors that contribute to high stillbirth rates in disadvantaged populations, including poor access to care and lower quality care. But I don't think there's been enough attention to systemic factors, by which I mean structural racism, inequity, fatalism that's ingrained in many in the medical professions, and the power imbalance between doctor and patient. What's one thing you could do? Acknowledge structural racism as a cause of higher stillbirth rates in Black Americans and other marginalized populations, and get the data you need to call for change in your state or community. Unfortunately, we still face an uphill battle against fatalistic attitudes of many caregivers and health policymakers around the world who still do not know that most stillbirths are preventable and still think that most stillborn babies were never meant to live. What's one thing you could do? Find out how health workers are taught about stillbirth in your own state and identify gaps that might be perpetuating fatalism in your own healthcare communities. Then take action. One result of fatalism and stigma is insufficient funding and research into causes. This global survey of 500,000 stillbirths found 860 terms used for causes of stillbirth, but still 1/3 were unexplained. And this report from the US Department of Health and Human Services found that 1/3 were unspecified, even though 3,000 codes were used for cause of death. Even in this study from the National Institutes of Health that was purposely built to identify causes of stillbirth, found no cause in 1/4 of them. So what's one thing you could do? Find out how much is being spent on stillbirth research in the US and use that data to call for change. So is there anything in our favor in the fight against stillbirth? Sadly and ironically, the strongest factor in our favor is just how bad it actually is. The global burden of disease has quantified morbidity and mortality for 30 years, helping to spotlight public health shortcomings and focus investment on the biggest gaps. In 2019, 5 million children died before their 5th birthday, of whom 1/4 were newborns. But in 30 years, the global burden of disease has not included stillbirths. If the 2 million stillbirths were included, this pie chart would look very different, with stillbirths comprising nearly 1/3 of deaths of children under 5. Another way to think of it, it's not totally legitimate since I always say that stillbirth is a time of death, not a cause. However, I think it's really interesting that out of all 59 million deaths around the world in 2015, if we included stillbirths, 4% are stillbirths. In fact, if stillbirths were momentarily viewed as a single cause of death grouped together, they would be the 5th leading cause of death worldwide. And in the US, more than half of all deaths before, during, and soon after birth are stillbirths. So what's one thing you could do? Find out the rates of stillbirth compared to newborn death in your own state and see whether you think that health budgets and policies reflect the picture that your data shows. So when I reviewed Schiffman's framework to adapt it to stillbirth, I found that it was really comprehensive with one exception. As happens all too often, there was no place in the framework to mention us, parents. We know the story. As with stillbirth generally, parents who are bereaved by stillbirth are usually invisible. At most, it's our grief that might be acknowledged. But parents are also experts and allies. This is Christine Wangechi. She's a 36-year-old accountant and a mom of two, an 11-year-old son, and a baby who was stillborn at 32 weeks on September 22nd, 2019. I'm really proud that the International Stillbirth Alliance was able to make space for Christine to speak her truth at the global launch of the first ever regular stillbirth estimates by the United Nations. You can see Christine in the red box next to key speakers from UNICEF, the Gates Foundation, and various national ministries of health. Christine shared her story and called for action. What's one thing you could do? Change the way the research and clinical community views parents by treating us as experts and allies, not victims or afterthoughts. Give us state and national platforms to say what we know. A final factor that's hindered progress is the sparse global network for stillbirth prevention. For the Lancet's Ending Preventable Stillbirth series in 2016, we conducted an analysis of global networks for maternal health, newborn health, and stillbirth. So here's a map of what those combined networks look like. And here's the map for stillbirth alone. Without going into the details, you can see that it's very sparse. There were many missed opportunities for collaboration. So as chair of the ISA, I really want to make a pitch to each of you to consider joining us. This map shows the locations of our members and some of our activities. We are honored and strengthened by every parent, family member, clinician, and researcher who joins us because we're trying to connect the world. I was supposed to provide some lessons learned, and here are some of them. Change cannot happen if we aren't talking. Use social media, conventional media. Talk with your friends and family. Talk with your doctors about stillbirth. Inequity in health outcomes will not change without systemic improvements, including ending structural racism. Think big and take a stand. Visuals are powerful. Show the invisibility of stillbirth in your community. Learn about and leverage politicians' commitments for better public health. Benchmark and publicize progress against the best global performers. Demystify acronyms, platforms, global organizations, and plans so you can use them to call for change. Create a stillbirth scorecard for your state, county, or hospital and use it to call attention to gaps in quality and outcomes. Call for harmonization of state data collection and revision of federal fetal death certificates. Midwives, obstetricians, and other health professionals are allies. Build bridges and lobby to provide them with bereavement care training and funding to train more perinatal pathologists. Campaign for funding for more research for high-quality perinatal audit and autopsy and placental histopathology for all parents. And take every opportunity to provide state and national platforms for regular parents to call for change. But most of all, take the long view. It's been a long haul since 1948, but change is possible. Real systemic change takes decades because we have to get at the underlying root causes of what's perpetuating preventable stillbirths. So really what I hope you come away with from my talk today is that there are things that we can do to make a difference, whether that's nationally in Washington, in your home state, or in your local hospital, clinic, or circle of friends and neighbors. Just please make sure to talk about it. Thank you so much.
Hello, I'm Elizabeth Minton, and this is some pictures of my boy Solomon that was born at the end of December and died in early January, 3 weeks later. I'd like to go ahead and introduce Dr. Uma Reddy, who is a professor of obstetrics, gynecology, and reproductive sciences at the Yale School of Medicine and section chief of maternal fetal medicine. Dr. Reddy graduated from Brown University and received her MD degree from the Warren Alpert Medical School of Brown University. Dr. Reddy also earned a master's in public health, MPH, from the Johns Hopkins Bloomberg School of Public Health. She completed her residency in obstetrics and gynecology at the Johns Hopkins Hospital and remained there as a Robert Wood Johnson Clinical Scholar. She completed her maternal fetal medicine fellowship at Thomas Jefferson University. She was a faculty member at the University of Maryland School of Medicine prior to joining the National Institutes of Health, NIH, as a medical officer in the Pregnancy and Perinatology branch of the Eunice Kennedy Shriver National Institute of Child Health and Human Development, NICHD. Her research on stillbirth as part of the Stillbirth Collaborative Research Network, SCRN, preterm birth and labor management has had a profound impact on obstetrical practice both in the United States and internationally. She received numerous NIH awards for her role in advancing women's health research agenda nationally. Dr. Reddy has been selected to serve as a member of the American College of Obstetrics and Gynecology, ACOG, Committee on Practice Bulletins Obstetrics, Fellow of the American Gynecological and Obstetrical Society, and was selected as a Fellow in Executive Leadership in Academic Medicine, ELAM, program for women.
Hi, I'm Uma Reddy. I'm pleased to be able to speak to you virtually about an update on the management of stillbirth. Today, I'll be discussing the obstetric care consensus statement that was issued by the American College of Obstetricians and Gynecologists, as well as the Society for Maternal Fetal Medicine on the management of stillbirth. This document was issued in March of 2020. I'm going to define stillbirth, its impact in obstetrics, describe the risk factors, etiologies, and conditions associated with stillbirth, and describe the workup for stillbirth as advocated by this document. Infant mortality has decreased more than the stillbirth rate in the US. So this graph shows how infant mortality has decreased, whereas stillbirth or fetal deaths 20 weeks or greater has been completely stable and has not changed in over the past decade. So in the US, the stillbirth rate is 6 per 1,000. There are 23,000 stillbirths in the US every year. So that's 1 in 165 pregnancies. The lack of decline in stillbirth over the past decade, plus the decline in infant mortality, resulted in 2013 that the stillbirth rate was even greater than that of infant mortality. And when we look at the rate of early stillbirths, 20 to 27 weeks, and then 28 weeks or more, you can see that the rates are equivalent, about 3 per 1,000. So I'm going to review the maternal conditions associated with stillbirth, the fetal conditions associated with stillbirth, obstetric conditions associated with stillbirth, then other conditions, and then unexplained or stillbirths that, despite a complete workup, have no explanation. So this just shows in the US the racial disparity in stillbirth. So you can see that non-Hispanic Black women have double the rate of non-Hispanic white women of stillbirth. This is a paper where we looked at maternal age, the independent effect of maternal age on the stillbirth risk. And what you see is these are about 5 million pregnancies where we took out chronic medical conditions, and we also took out fetuses that had anomalies. And that, this top graph is women who are 40 years or greater at the time of delivery. And you see, basically starting at 32 weeks, there is an increased risk of stillbirth, which dramatically takes off at 38 weeks. This line is women 35 or over. You see they have an increased risk of stillbirth, increasing at 37 weeks. And then these are the rates for 35 and under. Assisted reproductive technologies we know is associated with an increased risk of stillbirth. This is due to an increased rate of multiple gestations, but even for singleton pregnancies, there's a 4-fold increased risk of stillbirth for IVF ICSI pregnancies versus spontaneous pregnancies. The reason for this increased stillbirth risk is unclear. It's not clear, it wasn't clear for a long time. Was it the underlying infertility that led to the stillbirth, predisposed to stillbirth, or is it something in the IVF ICSI process? In one of many papers now, we understand that when you look at women who have IVF and ICSI and you compare them to a group of women who took more than a year to get pregnant or used non-IVF assisted reproductive technology, that there is an increased risk of stillbirth. So that indicates that there is something with the ART process that increases the risk. Obesity is associated with conditions that increase the risk of stillbirth. So diabetes, major congenital anomalies, preeclampsia are increased in women with obesity. But even without any of these conditions, obesity by itself is an independent stillbirth risk factor. Smoking is a modifiable risk for smoking. There's a 36% increase in the odds of stillbirth for women who smoke. And women who quit smoking between the first and second pregnancies, their stillbirth risk declines to that of non-smokers in the second pregnancy. This is a graph that a chart that just shows various maternal conditions, the prevalence, and the stillbirth rate per 1,000. And so just remember, in the US, the rate is 6 per 1,000. So chronic hypertension, there's an increased risk of stillbirth anywhere from 6 to 25 per 1,000. Preeclampsia, 9 to 51 per 1,000. Preeclampsia with severe features, the risk of stillbirth is even higher at 12 per 1,000. Diet-controlled diabetes, gestational diabetes, and most studies, well-controlled gestational diabetes on diet, there is not an increased risk above the population. Insulin-requiring stillbirth is associated with an increased risk of stillbirth, anywhere from 6 to 35 per 1,000. And women who have type 2 diabetes have an increased risk of stillbirth compared to women with type 1 diabetes. We think that women with type 2 diabetes have other conditions that increase their risk, such as obesity, and then they're less likely to receive a preconception consult to get their blood sugars under good control prior to pregnancy. Lupus, even though the prevalence is very low, less than 1%, the rate of stillbirth is greatly increased, 40 to 150 per 1,000. Renal disease, like also, is very low, less than 1% prevalence, but also an increased risk of stillbirth, 15 to 200 per 1,000. Thyroid disorders, 0.2 to 2%, decreased risk of stillbirth, particularly for hyperthyroidism. And then cholestasis of pregnancy is less than 1.1%, but an increased risk of stillbirth of 12 to 30 per 1,000. So next, I'm going to move to fetal conditions. And fetal conditions, we divide into genetic conditions that are associated with stillbirth, infectious causes of stillbirth, and then I'll talk about fetal growth restriction itself. So genetic conditions, there are chromosomal abnormalities associated with stillbirth, there's syndromes and malformations, single gene disorders that are associated with stillbirth. There are X-linked conditions that result in male stillbirths. There are autosomal dominant mutations, so skeletal dysplasias, which are sporadic mutations associated with stillbirth, but there's long QT syndrome, which is parentally inherited associated with stillbirth, and then confined placental mosaicism, which is when the placenta has an abnormal karyotype, abnormal chromosomes, but the fetus has a normal karyotype. I'm going to focus on chromosomal abnormalities because that's the most common genetic condition associated with stillbirth. The rate is anywhere between, for 6 to 12% of all stillbirths, there's a chromosomal abnormality. The rate is underestimated because the failure to culture cells. There's an increase with chromosomal abnormalities if there's a malformation Also, with earlier stillbirths, there's an increased rate of chromosomal abnormalities. And similar to live births, the distribution is predominantly monosomy X and trisomy 21, and then followed by trisomy 18 and trisomy 13. Infections cause 10 to 25% of all fetal deaths, higher in developing countries, more common at early gestational ages in developed countries. So the mechanism of stillbirth: infection can directly cause fetal infection, damaging organs and leading to developmental abnormalities. There can be placental damage, there can be severe maternal illness, or intrauterine infection, which precipitates preterm labor. And when the gestation is periviable, that leads to a stillbirth. This is an example of a stillbirth from the second trimester, and this is the fetal spleen. And what you can see is that there's this cell, which is an erythroblast, and has marginated chromatid and amphiphilic intranuclear inclusions. And this is significant for parvovirus B19. And this is important because this is not something that will recur, parvovirus B19. In one study in Sweden, 8% of all stillbirths had evidence of parvovirus B19 by PCR. We know the virus is trophic for fetal red blood cell precursors or cardiac cells. It attacks these cells, and it can cause anemia and high drops. But parvovirus B19 can also directly attack the fetus's heart, causing direct myocardial damage, leading to stillbirth. This unfortunate baby has succumbed to CMV, which is the most common congenital viral infection in pregnancy. 1% of pregnant women acquire primary CMV during pregnancy. Primary CMV has the highest rate of transmission and the most severe consequences. CMV causes placental damage, fetal growth restriction, and has direct fetal effects that we can see on ultrasound. I need to mention COVID-19. So what is the relationship of COVID-19 and stillbirth? So in this one study, this was reported in a hospital in the UK, where they found that the incidence of stillbirth was increased. During the pandemic, there was a rate of 9.31 per 1,000 births, but versus 2.38 per 1,000 before the pandemic. However, all the stillbirths, none of them were associated with COVID-19. So the authors theorized that because of COVID-19, women were not seeking care promptly because of fears of COVID-19, and that's what resulted in the increased rate of stillbirth. However, with larger numbers, the CDC has shown that there really isn't a relationship between COVID-19 and stillbirth. The CDC collected pregnancy and infant outcomes among 4,442 women who had SARS-CoV-2 and known pregnancy outcomes. And as you can see, the miscarriage rate was 0.3%, the stillbirth rate was 0.4%, so not higher than the general population. There was a higher rate of C-section at 34% versus 31.9%, and a higher rate of preterm delivery, with preterm delivery less at 13% in COVID positive women versus 10% in the population rate. Outcomes did not differ by maternal symptom status, but only 8.5% of women were asymptomatic in this study. Fetal growth restriction is accompanied by stillbirth often, but we need to understand why the fetus is growth restricted. It's by itself not a cause of stillbirth. So this just shows that if you look at babies that are less than the 3rd percentile, which is this green line here, there's a much increased risk of stillbirth as gestational age goes on. And it really takes off starting at 37 weeks. There's a much increased risk. This is the 3rd to 5th percentile, and the risk starts to take off at 37 weeks. And then for the 5th to 10th percentile at 39 weeks. you see an increased risk. So in summary, compared to the less than third percentile, it has a 3-fold increased risk versus the 3rd to 5th percentile, and a 4 to 7 times stillbirth risk compared to the 5th to 10th percentile. Obstetric conditions: abruption, cord prolapse, cervical insufficiency, preterm labor, pre-labor, a rupture of membranes can all cause stillbirth if it occurs at a periviable gestation, because you're not going to intervene by performing a C-section. Fetal maternal hemorrhage occurs in 4% of all stillbirths, and it depends on the volume of blood transfused. 50 to 75% of the total fetal placental blood volume needs to be lost to result in stillbirth. You need a reliable method for identification and quantification of fetal maternal hemorrhage, ideally before labor induction, and there should be evidence of hypoxia, anemia, on autopsy. Umbilical cord accidents are associated with 10% of stillbirths. Possible mechanisms include cessation of blood flow, intermittent disruption of blood flow, fetal blood loss, cord entanglement, but you have to be careful. 30% of normal pregnancies, there is a nuchal cord. So to establish causality, cord occlusion and hypoxic tissue injury and autopsy, and excluding other accepted causes of stillbirth helps you understand if umbilical cord accidents are the cause of stillbirth. So what is the optimal evaluation of stillbirth? It's very controversial. There's cost versus the yield. So you need to focus on common causes, focus on recurrent conditions, pay attention to clues, and of course, it's emotionally challenging with very levels of comfort with autopsy and genetic testing. So according to the ACOG stillbirth obstetric care consensus, a new document, you should definitely do a thorough clinical history, fetal autopsy, placental evaluation, fetal karyotype, and microarray. So microarray picks up small changes in DNA, so small deletions and duplications that cannot be picked up by karyotype, but can be associated with stillbirth. Screen for fetal maternal hemorrhage, lupus anticoagulant screen, anti-cardiolipin beta-2 glycoprotein antibodies have been also associated with stillbirth. And if this is diagnosed, then for the next pregnancy, you could treat with heparin, and then syphilis if that hasn't been performed before. Tests that are performed in selected cases include testing for specific infections, the maternal serum and fetal tissues, additional genetic testing depending on what you find on autopsy. In raccoons, it hasn't been performed previously. Performing glucose screening again, either with OGTT or hemoglobin A1C if the baby is large for gestational age, and then toxicology screening in select cases. Tests that are not useful are placental cultures, routine torch titers, ANA testing, testing for large numbers of thrombophilia, and then bile acids, glycohemoglobin, or thyroid function if there are no features of the disease, meaning that if a woman is asymptomatic, that just testing for bile acids or for thyroid disease or glycohemoglobin will not be useful. What about pregnancy after stillbirth and management? And this is a very difficult pregnancy for families. So you really need to be there to support them. At the preconception or initial prenatal visit, obtaining a detailed medical or obstetrical history, getting the evaluation or workup of the previous stillbirth, determination of recurrence risk. There's an increased risk of recurrent stillbirth, 5-fold increased risk in the next pregnancy, smoking, alcohol, illicit substance cessation, weight loss in obese women pre-pregnancy, genetic counseling if a family genetic condition exists, performing a diabetes screen, testing for lupus anticoagulant, anti-cardiolipin antibody, and beta-2 glycoprotein, and if that hasn't been performed yet, and providing support and reassurance. In the first trimester, dating ultrasound by crown lump length is important to have a sure due date. You can perform first trimester screen or cell-free fetal DNA testing, and then support and reassurance. Second trimester fetal anatomic survey at 18 to 20 weeks. You can offer genetic screening if it wasn't performed the first trimester, and MSAFP if the first trimester screen was already performed, and then support and reassurance. In the third trimester, serial ultrasounds starting at 28 weeks are recommended to rule out fetal growth restriction. As I showed you, that the risk of stillbirth goes up if with fetal growth restriction. Fetal movement counting starting at 28 weeks. Antepartum fetal surveillance starting at 32 weeks or 1 to 2 weeks earlier than the prior stillbirth. And then at delivery, this is a big change. So prior, it was that delivery could be done at 39 weeks if there was no indication for an earlier delivery. So the statement has been changed with this latest guideline. And so planned delivery at 39 weeks or as dictated by other maternal or fetal comorbid conditions. In cases of severe patient anxiety, where there is a preference to proceed with early term delivery, such decisions must incorporate the understanding of the increased risks of neonatal complications with early term delivery compared with the potential benefit. So basically, performing a delivery at 37 or 38 weeks, can be done as long as the woman and her partner understand the risks of the neonatal risks with an early term delivery compared to waiting to 39 weeks. So I just want to spend the last few slides on research on prevention. This was a well-done trial by Jane Norman and colleagues called AFFIRM, the Awareness of Fetal Movement and Care Package to Reduce Fetal Mortality. So they studied a reduced fetal movement care package, which included increasing women's awareness for prompt reporting of reduced fetal movements, and then also performing standardized management, CTG, NST, amniotic fluid assessment, growth ultrasound, including timely delivery for women reporting reduced fetal movements. They looked at 409,000 pregnancies. And what they found was the stillbirth rate was 4.4 births per the control period. So before this package of interventions was introduced, and then after the intervention was introduced, it was 4.06. So basically there was no difference by using this reduced fetal movement package of making women aware of fetal prompt reporting of reduced fetal movements and the standardized management. And in fact, there was an increased risk of induction of labor, C-sections, and prolonged NICU admission after the intervention period. Antenatal testing for advanced maternal age. This is a hot topic. Women 35 and over comprise 15% of all births in the US. Women 40 and over, 3% of all live births. So the ACOG committee opinion just came out, actually, SMFM. So this just came out a couple of months ago on indications for outpatient antepartum fetal surveillance. So what does it say? It says for maternal age greater than or equal to 35, antepartum fetal testing should be individualized based on cumulative risk when present with other factors. So what that means is that they're leaving it to the practitioner to individualize it. And if there are other risk factors, then you may want to perform antepartum testing. There are very few studies directly looking at this. This is a study that was done of 4,469 singleton pregnancies. 34% of the women were advanced maternal age and 65% were not advanced maternal age. For the women who are advanced maternal age, they did weekly biophysical profiles starting at 36 weeks and planned delivery 41 weeks or sooner if indicated. They took out fetuses with lethal and chromosomal abnormalities. And what the authors found was that stillbirth in the advanced maternal age tested group was similar to that of the non-advanced maternal age group. So the rate 3.9 in the tested group versus 3.4 per 1,000 were similar. And so the authors concluded if there isn't the increased risk of stillbirth, as I said, there's usually a 5-fold increased risk in stillbirth. That since the rates were same, testing must work. This is very indirect evidence. What about obesity? We talked about that as being a risk factor for stillbirth. So this is a paper that looked at thousands of stillbirths. And what they did is they looked at it by BMI, body mass index here on the x-axis, and the risk of stillbirth. And what you see is over here on the x-axis, I'm blocking the number 40, but a BMI, body mass index of 40, that the relative risk of stillbirth is twofold increase. So this is similar to the risk with hypertension and diabetes, so increased risk. And so what is this recent ACOG committee opinion SMFM document on indications for outpatient antepartum fetal surveillance say? It says that if the pre-pregnancy BMI is 35 to 39.9, that just you should do antepartum fetal surveillance starting at 37 weeks. And if the pre-pregnancy BMI is 40 or above, that you should start weekly antepartum testing at 34 weeks. What about timing of delivery or induction as an intervention? So the ARRIVE trial, a randomized trial of induction versus expectant management, studied the question if elective induction of labor in nulliparous women at 39 weeks improves perinatal outcome compared with expectant management. The primary outcome was a composite of stillbirth or neonatal death or severe neonatal morbidity, and the sample size was 6,100. And this study was very important to do because previous studies, the thought was that induction of labor increased the C-section rate. So really you shouldn't do an induction unless there's a reason to do an induction, a medical or obstetric complication. However, the comparison group in all those studies were women who were already spontaneously laboring. And if you can think about this, if you're already spontaneously in labor, you're that much closer to having a vaginal delivery and have a decreased risk of C-section, when really the comparison group should have been women who you leave alone at 39 weeks. So either you can induce a woman at 39 weeks or you can continue prenatal care until she goes into labor on her own or needs to be induced for some other reason. So this trial was patterned on, comparing these two groups. And what they found was the primary perinatal outcome was 4.3% in the induction arm and 5.4% in the expectantly managed arm. So the relative risk was 0.8. So the risk of the primary outcome was reduced in the induction arm. However, just statistically, we said this was not significant, and it's because this confidence interval includes 1. So we said there was not a significant difference. When we looked at respiratory support, the induction arm had a lower rate of needing respiratory support compared to the expectantly managed arm. The induction arm had a lower rate of C-section, 18.6% versus 22.2% the expectant arm. And why is that? Why would expectantly managed women have a higher risk of C-section? And that's because at 39 weeks, if they're not favorable, they can go to 41 weeks and not be favorable, and yet the baby has gotten that much bigger. Women develop preeclampsia, oligohydramnios, placental issues develop. So there are a whole host of reasons why the C-section rate ends up being higher. And then one of the explanations is hypertensive disorder of pregnancy. Induction arm had a much lower rate, 9.1% compared to the expectantly managed arm. So really in the ARRIVE trial, the induction of labor arm had all the benefits. So this was an interesting editorial about antepartum testing for the prevention of stillbirth. Where do we go from here? And the author stated, beyond 39 weeks of gestation, if the established risks of stillbirth are deemed unacceptable, delivery is a more rational and evidence-based approach than antepartum testing. Meaning, instead of doing non-stress tests, it would make more sense to deliver women at 39 weeks if you're concerned about the risk of stillbirth. What about low-dose aspirin? It's widely available. It has anti-inflammatory effects. It impacts blood flow. There are few maternal side effects. It's safe during pregnancy, and it's inexpensive. So this was a study done by the Global Network They did a study called the aspirin supplementation for pregnancy indicated risk reduction in nulliparous aspirin. And this study was based on the fact that another study showed that women who took aspirin, low dose aspirin, before trying to conceive actually had a lower rate of preterm delivery. So this study was based on that finding. And the primary hypothesis was that nulliparous women treated with low dose aspirin starting at 6 to 13 weeks gestation through 36 weeks gestation will reduce the rate of preterm birth. This was done in low and middle income countries, and this was a prospective randomized placebo-controlled trial. 11,976 women were included, and there was a secondary outcome of stillbirth. So what were the results? Low dose aspirin was associated with a lower risk of preterm delivery, less than 37 weeks, 11.6% versus 13.1%. It was associated, low dose aspirin was associated with the decrease in perinatal mortality, so death greater than 20 weeks, and neonatal deaths less than 7 days, and decrease fetal loss, which was defined as death after 16 weeks and before 7 days postpartum. So aspirin did reduce stillbirth. Genomics is another area. There's a lot of research going on. So long QT syndrome, or LQTS, we know it's associated with 9.5% of SIDS cases. So if you imagine sudden infant death syndrome, there's a continuum that, term stillbirths. These stillbirths, unfortunately, we don't find a cause for them. So could it be a continuum from SIDS to these term late stillbirths that are unexplained? So these authors did targeted sequencing on a panel of 7 genes associated with cardiac channelopathies and cardiomyopathies. So these basically cause long QT syndrome. And what they found was there were pathogenic variants, meaning variants that are associated with disease in 12% of the 290 cases of stillbirth. So, indicating that there is a continuum probably between these unexplained late stillbirths and sudden infant death syndrome. And then now we're looking to exome sequencing. So as you know, this is a chromosome and there are genes, and the gene is, the parts of a gene is there's a non-functional part of the intron. There's the exon, which is a functional part of the gene, and this is responsible for making the protein. And then what is the exome? It's all these exons in a genome. So when you sequence all the protein coding regions of a gene in a genome, that's called whole exome sequencing. So whole exome sequencing, we're sequencing all the functional parts of the gene. So in the Stillbirth Collaborative Research Network, which is a study that took place in 2006 to 2008, we did whole exome sequencing of the stillbirths. So we had 246 stillbirths where there was normal microarray. So they had normal karyotype, normal microarray, so and no identified cause. And what we found was 6.1% of cases had 7 known disease genes implicated in stillbirth. There were 2.4% of cases that had a suggestive genotype in either the known stillbirth gene or a gene candidate. So whole exome sequencing found a probable molecular diagnosis in 8.5% of cases. So based on what we know about stillbirth from the Stillbirth Collaborative Research Network, 18% of all stillbirths had a known genetic cause. 6.9% of the aneuploidy, which is when there's a chromosome missing or additional chromosome. 2.6% had the pathogenic copy number, which means they had on microarray either additional micro deletion or duplication of genetic material, which is known to be associated with stillbirth, and then another 8.5% by whole exome sequencing. So I'm going to end here with Lighthouse State Park in Connecticut, which is nearby, and thank you for your attention.
Hi, I'm Danielle Otland,
And I'm Mike Otland.
and we're Jude's parents.
We're here to introduce Miss Tamara Esconuela Sanchez. She's a psychology graduate with a master in general health psychology from the University of Barcelona, currently conducting a PhD as part of the Pregnancy Loss Research Group at the University College Cork in Ireland. The aim of her PhD is to develop an evidence-based behavior change intervention targeting the modifiable risk factors for stillbirth.
Mrs. Canuela Sanchez's presentation today is titled Facilitators and Barriers to Seeking and Engaging with Antenatal Care in High-Income Countries, a Metasynthesis of Qualitative Research.
Hi, welcome to my presentation. My name is Tamara. I'm a PhD student at the Pregnancy Loss Research Group and the Infant Center at University College Cork in Ireland. I'm here to present our work entitled Facilitators and Barriers to Seeking and Engaging with Antenatal Care in High-Income Countries. So let me just give you a little bit of background to put our study in context. Previous studies have associated inadequate attendance at antenatal care with negative maternal and fetal outcomes, including increased risk of stillbirth. We know from the conclusions obtained after the publication of the stillbirth series in The Lancet that a large proportion of stillbirths in high-income countries are associated with factors that are avoidable. And so it highlighted the importance of increased clinical and community awareness of those modifiable risk factors associated with stillbirth. According to the WHO, antenatal care can be defined as the care provided by skilled healthcare professionals to pregnant women and adolescent girls in order to ensure the best health conditions for both mother and baby during pregnancy. Within its continuum, antenatal care provides an opportunity for communication, health promotion, prevention, screening, and diagnosis of diseases. The WHO recommendations on antenatal care include a minimum of 8 contacts. 5 in the 3rd trimester, 1 contact in the 1st trimester, and 2 contacts in the 2nd trimester. Minky and Blondell conducted a study a few years ago to compare the levels of utilization of antenatal care in different European countries. The authors concluded that the proportion of late attendees was low in Finland, France, and Italy, was moderate in Belgium, Germany, Norway, and Sweden, and it was high in Greece, Ireland, and Portugal. As I mentioned before, previous studies have associated inadequate attendance at antenatal care with negative maternal and fetal outcomes. Stacey et al. Reported that women who attended less than 50% of the recommended antenatal visits were 3 times more likely to suffer from late stillbirth. And a trend analysis found a significant relationship between decreasing visits and an increased risk of stillbirth. This lack or delay of antenatal care might be preventing healthcare professionals to identify issues during pregnancy. Also, antenatal care is an opportunity for healthcare professionals to provide women with vital information about their health, which could lead to healthier lifestyles during pregnancy, decreasing the risk of adverse outcomes. So the aim of this study is to understand women's attitudes, perceptions, and experiences of antenatal care in order to identify facilitators and barriers to seeking and engaging with their antenatal care. And we decided to do so by conducting a metasynthesis of qualitative research. So I'm going to quickly talk to you about our methods. A metasynthesis is a systematic review of qualitative studies. So the first steps are similar to any other systematic review process. We designed a search strategy that we ran through 5 different databases, and we conducted the screening of titles, abstracts, and full text using our eligibility criteria. So our eligibility criteria was as follows. We searched for all qualitative or mixed method studies that included pregnant or women up to 12 months postpartum, conducted in high-income countries, and we searched from inception until November 2020, moment in which we last updated our search. To assess the quality of the included studies, we use the Critical Appraisal Skills Program, or CASPS. To assess our individual review findings, we use the circle approach. This approach facilitates assessment of how much confidence can be placed on individual review findings from a synthesis of qualitative research. Our synthesis was informed by metaethnography. Metaethnography is an interpretative approach originally developed by Knowledge and Here that facilitates putting together all of the research available by translating qualitative studies into one another. Knowledge and Here proposed a series of phases that overlap and repeat along with the conduction of the synthesis. So phases 1 and 2 involved identifying a research interest and gap and their objectives and identifying the relevant literature. These steps were completed through a systematic search of the literature that I just explained. Phase 3 involved reading these studies in depth in order to become familiar with them. During this phase, data from the studies were extracted. To do so, each paper was read carefully and notes were taken identifying the different data that need to be extracted by one author. During phase 4, the studies were imported into in vivo trial to facilitate the identification of concepts and themes. We conducted the line-by-line coding of the results and discussing section of each study, consulting with the rest of the team when in doubt. Once the initial coding was completed, the text added to each code was then examined to check consistency of interpretation, and additional coding was performed when necessary. We obtained a list of concepts that were grouped into themes and categories using thematic analysis. Phases 5 and 6 involve translating the studies into one another and synthesizing those translations. The themes were further refined through the coding process to identify if themes reflected the meanings of each individual studies. The initial codes and themes were examined and combined when they described similar findings. And to establish the relationship between the concepts, we utilized concept maps, stating the influence of each concept over the other. And these maps were discussed with the research team. Okay, so moving on to our results section. If you remember our systematic review process, our first search identified 5,499 potential studies. After removing duplicates, 4,517 titles were screened, and 4,336 titles were excluded. 188 studies remain eligible for abstract screening, which resulted in 18 studies potentially eligible for full-text screening. Finally, after full-text screening, 15 studies were included in this synthesis. As per the characteristics of the included studies, 14 of them were qualitative and 1 used mixed methods. They represented 6 different high-income countries. 4 of them included pregnant women only, 5 included postpartum women only, and 6 included both. And the timing of publication of the study was from 1994 to 2020. Okay, so now moving on to the actual findings of our synthesis. We were able to identify facilitators and barriers at different levels within society. First, we identified facilitators and barriers associated with the individual pregnant women. Then we identified facilitators and barriers associated with individual healthcare professionals. Then we identified facilitators and barriers associated with the healthcare system. And finally, we identified facilitators and barriers associated with the social environment. So I will begin by explaining the woman's individual factors. Within this theme, named Attitudes Towards Pregnancy and Antenatal Care, we identified several emotional processes that have an influence on women's decision-making. For example, having feelings of ambivalence towards pregnancy, denying the pregnancy, feeling overwhelmed or unprepared to be a parent, worrying about social services environment, and fear play a very important role that can act as barriers for women to seek antenatal care. Our analysis identified that not having a planned pregnancy also identified these failings and acted as an additional barrier. We have here an exemplifying quote, where one woman said, "It actually took me a few weeks to feel anything. I didn't feel anything because it wasn't planned." Or this other one, from a woman who took time to consider terminating her pregnancy. "Well, I didn't start mine right away because I went straight to the abortion clinic. Like I said at the beginning, I wasn't happy." We also identified certain beliefs and attitudes that acted as barriers. For example, some women attributed low value to antenatal care, and some others understood pregnancy as a normal life event that doesn't require medical attention. An example of this belief is also expressed in this quote. Walking late is not a big deal to me. Number one, it is not a disease. I am not sick or anything, so I knew what was wrong with me. Additionally, we also identified that having previous negative experiences related to healthcare in general led some women to mistrust the system, and it also acted as a barrier to seeking antenatal care. However, we also identified certain attitudes towards pregnancy and antenatal care that acted as facilitators. For example, women having positive feelings towards the pregnancy, actively planning the pregnancy, were mentioned as facilitators. One example of having positive feelings towards pregnancy is shown in this quote. You can always feel this presence, and you can almost, it sounds stupid, but bond with the baby because you feel like you're together. Adopting an active role in their care, viewing antenatal care as an opportunity for behavior change and understanding the benefits of antenatal care were attitudes and beliefs that acted as facilitators. Some women perceive antenatal care as acting as a preventive measure, being a source of knowledge, support, and reassurance, and acting as a distraction and a means of socializing and peer mentoring. Again, some examples of this can be seen in the following quotes. It would frighten me not to have it, to go through a whole pregnancy without it. It would frighten me when I'm in the labor room. It's very important. Prenatal care, it helps you feel a little bit safer, comfortable about what you're going through. Sometimes we get nervous, you don't know. So moving on to the next group of things that we identified. This group of things outlines specific behaviors or attitudes adopted by healthcare professionals that might have had an influence on the woman's perception of care and their willingness to engage with the antenatal care. Firstly, we identified issues related to healthcare professionals' attitudes. Some women in the studies, especially those from ethnic minorities, reported feeling judged and stigmatized by healthcare professional attitudes. Further, some racist behaviors and a feeling of inequality between patients and professionals were also reported in several instances. Also, several women reported lack of empathy or insensitivity from some healthcare professionals. In some studies, women felt like they were not treated with respect and that healthcare professionals were too task-oriented. We see an example of this bias treatment in the following quotes. Providers that act like I don't know anything just because I'm poor. I want to learn. Didn't get nothing out of it. Keep repeating. Feel like I'm not smart enough to ask questions. Or for example, this one. She just came in and it's like she is so used to it and you're just another pregnancy. So she doesn't see you for an individual. She just does her thing and leaves. Additionally, we also identified communication issues that were reported through the different studies. Women reported receiving contradictory message, having concerns dismissed, feeling uninformed, being confused due to the use of jargon, and feeling frustrated since healthcare professionals would not do any prior health knowledge assessment. This poor communication not only might have altered the woman's subjective perception of their care, but also of the whole antenatal process in some instances. It might have led women to disengage and lose interest in their antenatal care. We have another example of this issue in the following quote. They didn't really go over what to expect or what to do when this happens. They didn't really go over how the day would go, I guess. However, in other cases, women also reported different attitudes that healthcare professionals adopted to facilitate the antenatal care process for them. These attitudes influence the woman's perception of the carers in a positive way and made them feel cared for and valued. Not judgmental, honest, supportive, and empathetic healthcare professionals were highly valued. Positive communication also helped women through their antenatal care process. Healthcare professionals who engaged in active listening and took time to address women's concerns, empowered them to participate in the decision-making process, were seen as very encouraging by women and facilitated trust. We can see two examples of these here in these quotes. I just feel they relate to a lot of things. Say you going through things that you're dealing with, and when you find yourself in, some type of crossroad, they help you, try to navigate your situation. I mean, I just think they go above and beyond their duties. Or this other one. The way she talks, the way she attends to you, you understand. That make you really feel good, you know. So moving on to the factors associated with the healthcare system. Within this section, we examine various facilitators that are associated with the organization, functioning, or management of the antenatal services or health services at an institutional level. So here, having an unsatisfactory clinical experience was reported by several women as a barrier to engage with antenatal services. For example, experiencing rush appointments, feeling that positive care was conditional on insurance status or some socio-demographic factors, feeling excluded from the decision-making, or feeling that the whole process was a waste of time. Additionally, sometimes women found barriers associated with the organization of antenatal care. Examples of these are administrative delays or problems with the referral process. Other women reported that the lack of flexibility meant that antenatal appointments clashed with their other commitments, which impeded their access. Some women found that the application to access antenatal care was too complex and required too much effort. In these cases, women were willing to access antenatal care early, but the application process itself was delaying them. We have a couple of examples of these issues here in these quotes. So for example, this one. It does take a long time because they don't take women without a GP at the hospital. So to get to the hospital, she needed to get to a GP, register with a GP, get an appointment, and for her to be referred to the hospital, it takes time. GP requires proof of address, some bill or something, and she did not have that address because they moved just recently, so she was waiting for proof to come. Another one is this one here at the bottom. I think that with welfare, you have to have predetermination, and I didn't do something right. I went to the doctor's office and they couldn't see me because I didn't know how to get Medicaid until I got there. Then I had to reschedule and wait for them to get like the verification that I had it. Additionally, a perceived lack of individualized care and lack of continuity of care were also reported as barriers. For some women, not seeing the same healthcare worker in each visit hindered their ability to build rapport and open up to them. And this drove some women to avoid antenatal care services and attend their general practitioners only for their care. Finally, we identified factors associated with the social environment of the woman. In this category, the barriers identified are related to the general socioeconomic, cultural, and environment context where a woman lives. Aspects like homelessness, intimate partner violence, living in deprived areas, having an immigration status, or having low economic resources have been identified as barriers to antenatal care attendance. Most of the time, women living in these conditions do not have their basic needs or survival covered and need to focus their efforts in their more immediate concerns. Therefore, seeking antenatal care is not a priority for them. We have some examples of these issues in the following quotes. But if the midwife at the hospital says, "You're not Danish, you can go home or pay." I was mainly worried about my children eating. I didn't worry about myself. Women from different cultural backgrounds also reported issues related to cultural inappropriateness or language barriers. Some of the studies included in the analysis look at the experiences of migrant women in high-income countries. Women felt discriminated against due to their immigration status, and in some cases felt they needed to justify their right to care, even in countries where this right is available for everybody. Women with an illegal immigration status were afraid of being deported if they attended antenatal care, and they were also afraid of being separated from their babies. Due to their legal immigration status, some women had uncertainties about the ability to afford care, which led them to believe that they only should access care in case of emergencies or when in labor. And on top of that, the lack of familiarity with the healthcare system in the hosting country increased their difficulties in accessing care. These women found that attending of health clinics held specifically for immigrant women facilitated their access to care, as they felt safe there, and many women depended entirely on these clinics. The analysis showed that the social discrimination of certain collectives within the society also acted as a barrier for many women. It was reported in different studies that teenage women, substance users, women from ethnic minorities, or women from lower socioeconomic status faced additional challenges when trying to access antenatal care. In some instances, women felt their care was of lower quality based on their insurance status. As an example, we have this quote here from an African American participant in the study. It's not going to change. It's not, because it's been like this forever. You learn to go last. No matter how much people talk about it, it is the same. Yes, it is. It's been like that forever. That's how it is. An absence of social support heavily influenced women physicians to attend antenatal care. In some cases, this lack of support was due to fear of disapproval within the women's community, or because the woman had moved to a different part where they didn't have connections yet. We have a quote here to exemplify this. Like I said, I just moved to Phoenix. They, the family, didn't really give a shit. It's just me and my problem for me to deal with, nobody else. Additionally, we also identified issues related to health literacy and reproductive knowledge. Many women in the different studies reported a delay in the recognition of the pregnancy due to these different reasons such as mistiming of the pregnancy, lack of knowledge of pregnancy signs and symptoms, attributing symptoms to other issues, having a history of irregular periods, not expecting the pregnancy, or not noticing the symptoms. Again, we have some examples of this issue in the following quotes. I just started throwing up. I just thought I had an upset stomach, so I waited for about 2 or 3 months and then I finally went to the hospital. Or this other one. When the GP said I was going through the change, I thought, well, could I be? Because at 37, I thought, well, I might be. Because you hear women go through it earlier than I did. And I think I got that into my head. More than anything, I never contemplated that I was pregnant. However, there are some lifestyle factors or social position-related factors that act as facilitators to access antenatal care. For example, having a higher educational level, a higher economic status, a steady living situation, being older, or being a first-time mom are factors associated with a better attendance and compliance with antenatal care. Women in more favorable socioeconomic positions are more likely to have less immediate concerns, and so they can focus on seeking antenatal care during their pregnancy. Furthermore, women with greater access to education information but might be more aware of the different risks during pregnancy and the importance of antenatal care. Availing of social support from their baby's father, the community, and the family, combined with a positive reaction, facilitated the process of acceptance of the pregnancy and promoted engagement with antenatal care. We have an example of this here in this quote. Because of my other job, they are so supportive about the situation because they know I really didn't want to have any more kids, but they are very supportive. So to finish up, let me expose some important learning points or take-home message that we obtained from this study. The first thing that is important to know is that even though we have divided these different factors in groups, themes, and categories, these factors can co-occur, and it's essential to keep them all in mind to understand the whole picture. So we consider that interventions need to be designed to tackle this issue at different levels beyond the individual. We think that healthcare professionals should be encouraged to use sensitive communication styles and take time to build a positive rapport with women to facilitate engagement. Additionally, health literacy and reproductive education should be promoted from the preconceptual period to facilitate family planning and pregnancy symptom recognitions. And finally, we consider that the identified social determinants of health should be addressed at the different levels. Policymakers should tackle this issue in terms of health, education, employment, housing, and social equality. So that is everything from me. Thank you so much for your time and attention. Please get in touch with me if you have any questions, and I look forward to your comments. Thank you.
you.